and we are third year DPT students at Ohio University. We're in a running elective right now, and for this running elective, we are supposed to interview or do a journal club, and we chose to interview you because we have some interest in working with athletes in the future. So we'll go ahead and get started. Becca has the first question for you.
Yeah, Maddie, so if you don't mind just filling us in a little bit on like sort of your background versus like your education, your background with what or with running, and then like why you chose to get into running.
Yeah, that's a great question. I've been running kind of my whole life. I ran in high school. I ran an undergrad for running club for college. So I did like half marathon and marathon distance. For DPT school, I went to Ohio State. And while I was at PT school, I kept running recreationally. I always loved to run. But then clinically, I knew that I was interested in it. So I kind of did two running projects with my DPT career. The first of which was I did an inpatient rotation where we focused on gait analysis and stroke patients. So that was really cool. We had one patient that wanted to get back to running. So obviously, I love that. But I do really like working with the younger athletes. So the other rotation that was really important to me was I had a rotation with Cincinnati Children's in their gait analysis lab. So if you like running, I worked with Jeff Taylor Haas, which is a big name in the pediatric running community. But that was really cool. With that, we looked at a lot of cross country runners, soccer runners, track runners. I ended up taking some of the data that we collected and I made a CSM presentation. So we looked at female versus male kinematics in runners versus soccer players. Found there wasn't a big difference in sport, but there was a big difference in gender, which we see a lot in the running population. So that was my last year of PT school, but then I decided that I wanted to do a sports residency because I loved athletes, wanted to learn more about like the pediatric athlete. So I did my sports residency at Nationwide, which is where I met Bill. He's one of our lecturers there. He's a funny guy. Um, but yeah, so I did my residency year, and now I've worked at Nationwide for the 2.5 years since my residency ended. I'm the head of our running SIG, so it's just a special interest group of PTs that are interested in running. We kind of do our own kind of research and our own kind of projects. Some of the projects that we've just done, we just updated our running progressions for different age groups, so like the 3 to 6 like grades, 7 and 8, and then high school standard, high school conservative, and then our sprinting progressions. So that's kind of where I'm at right now. What got me into running is just my personal recreational interest. And then there's a lot of research out there. So I feel like this is a population that we see a lot. We don't always see them in PT, but there is a lot of injuries in this population. So there's a lot of areas that we could probably learn and get a little bit better at treatment with them. So that's kind of my background with this.
Yeah, that's awesome.
Kind of on a related note, what got you into like pediatric running specifically? Because obviously that's like a very niche community.
Yeah, so my involvement with pediatric running, I was a coach for Girls on the Run when I was in college. And I just loved it, especially like early on, teaching these girls like strong, confident morals, but also like involvement in community, involvement in running. I would say that really sparked my interest in like seeing people who are first starting getting in running. Because if you've ever seen a kid run, their running form is not perfect. So it's very different from like the high school, the college athlete. But I would say it's just like the community aspect. I think that's the part that draws me the most. These people are really passionate. Across country meets, everyone just cheers for everyone. It's kind of amazing. It's very different from any other kind of sport I've seen.
Yeah, no, that's great. On kind of a similar note about like pediatric running, what population of patients do you work with, and like what percentage of your caseload is pediatric runners?
Yeah, that's a good question. So our age range is kind of wide. So the youngest that I'll work with is usually like the 5-year-old. We don't get them very often, but sometimes, just general sports and ortho fractures or muscle strains. The oldest that I ever work with is usually 24 because I do coverage at our ODU clinic. So I do work with a few college athletes, so I see some runners with that. The majority of my runners, I would say, are the middle school and like the early high school population. Middle schoolers are probably like the bulk of our caseload. So, in terms of running, I would say my caseload percentage depends on the time of year. Right now, it's the heaviest that it is with runners with cross country season just ending. We have a lot of people come in. They're like, yeah, I had this pain all through the season, but now I'm coming to see you.
Mhm.
I'm like, cool, cool, cool. I'm glad we're not doing anything during the season. Definitely, I would say at its most, maybe like 30%. It's not super niche. Like I don't see like the majority of my caseload.
Mhm.
I would say the majority of my caseload, I see a lot of ACL surgeries and a lot of like post-op patients. So knees in general, I would say in general are usually like 40% of my caseload, whether it's non-op or operative. But I would say the running at the very most is probably like 30%.
Mhm. Kind of going off of that, I know you said that you see like a lot of the knee patients like with ACL tears and all of that, but what is your like most common diagnoses involving running that you treat?
Yeah, so most common diagnosis just in general at Nationwide is going to be patellofemoral pain. That's definitely
Mhm.
the most common that we see, very common in runners. So that's probably the number one that I would think of. Number two is some kind of stress fracture. We see a lot of kids that come in either with like tibial stress fracture, femoral neck, sometimes like calcaneal stress fractures, but just kind of depends on the level that they're running. And then sometimes we'll see like hip apophysitis, so like a growth plate irritation. I would
Mhm.
say those are probably the top three most common for my runners.
Gotcha. Okay.
Awesome. So kind of getting into your evaluation and sort of what you do, how do you most commonly perform your gait analysis with your runners? Does Nationwide use like an app? Is it kind of person to person?
Yeah, so I do 2D motion analysis. So with that, we usually put biomarkers on their running just in different anatomical spots. Usually when I go in for the evaluation, so early on, some things that I use that are specific for runners, because obviously I'll do all my MMTs that I do on everyone. But some things that are specific to the runners is that we use the University of Wisconsin Running Index. That's an outcome measure for runners. Pretty sensitive. We like to use it just to see their confidence and how they're feeling with their running form. I'll do the running readiness scale, which is a scale that was developed by Otterbein University. It's a scale to determine like some anatomical and like biomechanical faults. So some of the tests that we look for that is like they have to do a plank, they'd have to do a wall sit with a med ball, they have to do step up, step down, single leg squats. A lot of them are to a metronome, which kind of like mimics the running with your cadence. But a lot of kids are not good at it. So I like to use that more as a screening tool to see like, okay, how heavily do I have to weight some of these biomechanical faults? Because realistically, the age population that I see, their running form's not going to be perfect because it's going to continue to change as they get older and they develop. So I usually use the running readiness scale to kind of put weight on, okay, if I'm seeing 15 biomechanical faults, what's going to be the most important for their injury type and what do I really need to focus on? So that's like the pre-running analysis. When I do the running analysis, all the anatomical markers are placed. We use OnForm for our 2D motion analysis. So it's an app on the iPad, take the video. I'll usually review it with them in the clinic, just like in real time, kind of say like, hey, this is what I see. This is what I saw during my evaluation. This is how it relates to your injury. And then I'll write up a paper for them. So just like a PDF, and I'll usually take time points on initial contact, mid stance, terminal stance. I like to do it from posterior, anterior, and lateral view. So just so I get kind of a full picture. But from there, usually in my write-up, I like to focus on like three things because runners can be very type A. And if I
Mhm.
gave them like 15 things, like everything that they need to focus on, that wouldn't help anyone. So I like to focus on like three major things based on my MMTs, based on the running readiness scale, and then based on the motion capture.
Okay, cool.
Kind of on like a similar note to that. So we talked about how you perform gait analysis. At what point do you choose to retrain gait with your patients? Like, do you commonly see like overstriding, so you want to manipulate cadence, or
Mhm.
how do you go about that?
It's a great question. For a lot of kids, what we'll do for the running analysis depends on what the fault that they have is. So you mentioned cadence, and like their like metronome and whatever. I'll train that occasionally if I notice that there's like a very large overstride, and that tends to be the issue more with like stress fractures or more of those
Mhm.
impaction kind of injuries. Typically for this population, because their running form is going to change so much as they age, usually my kind of like exercises I give them after the running eval are more like the dynamic warm-up drills, or they'll be strength supporting kind of like their X. So for the
Mhm.
running warm-up drills, I usually focus more on like, are they doing the correct form for like A skips, B skips, C skips, that kind of stuff?
Mhm.
Because when it comes to their running form, yes, is something that they can kind of think about when they're running, but I usually tell them I don't want you to think about your running form while you're running. I want you to, be in the moment, be present, be running, because there's
Hmm.
no quicker way to ruin running than to just be thinking, okay, step, step, step,
Hmm.
especially in a kid, that's a lot to take in. So
Hmm.
usually I'll like train them in like, this is how you do an A skip. I'll do a couple different dynamic drills with them, like a retro lunge to like a high knee drill. We'll do
Hmm.
like Captain Morgan's into the wall to work on glute med stability. A lot of times we work on bounding just to work on like rate of force and like power production. That way they're like actually kicking in their glutes when they run. But from a running retraining aspect, I don't usually get into that unless it's a surgical patient and I
Hmm.
see something that is really different side versus side.
Hmm.
Yeah.
What cues do you commonly use to like retrain mechanics when you do see it in like your post-op patients that you mentioned?
Yeah, so for a lot of post-op patients, especially ACL patients, if they're lacking like stance knee flexion, sometimes I'll give them the cue, okay, you're going to be running under a ceiling, or I want you to try and like hit my hand when you bounce up and down. And that
Hmm.
will get them a little bit more like knee bend, knee push off through it.
Hmm.
Sometimes I'll give them a video where I take a video from the side and I'll tell them, okay, this is what you looked like initially. I want you to try and correct it because kids will do crazy stuff, but sometimes they'll do something where I'm like, okay, what were you thinking of in that moment?
Hmm.
A lot of times for overstride, I'll kind of cue them, okay, I'm gonna have you lean forward a little bit, and I want you to almost feel like you're falling forward when you run. Usually when I do that on a treadmill, I'll put them on a little bit of an incline as kind of like an assistance for it, just because it can be really hard. If they're not getting it on the treadmill, we'll do it on a jump stretch band. That way they have that posterior pull, which can get a
Hmm.
lot of kids more comfortable with that lean forward that they're supposed to do when they're running.
Hmm.
Other post-op cues that I've found, I have to tell them to push through their toes a lot because usually plantar flexion's pretty affected after ACL reconstruction.
Hmm.
So hopefully we've been training soleus strength, but that's usually one that I have to tell them is like push all the way through your foot, push through your toes. Those are the ones that I use the most commonly, I would say.
Gotcha. Okay, great.
Sort of building off of your post-op and your fractures that you see most often, how do you sort of determine when a patient is ready to start returning to run or like giving them the go-ahead completely, like you're good to go?
That's a great question. So there's a few different things that I've kind of like adapted over the years. I do love the running readiness scale. It was originally designed to see like, are our patients ready to get back to running? Sometimes I'll use it as more of like a soft scale. So I don't look at it from the standpoint of biomechanical faults, but I'll use it more from the standpoint of can they do these things pain-free? Because it does involve like single leg squats, pogo hops. They have to do like planks and wall sets. So if it's not perfect, but it's pain-free, then we might initiate more like a plyometric progression. With plyometric progressions, I've gotten more in the habit of tracking like foot contacts over time. So if they're starting out their session and we do just like pogo hops or line jumps, then I'll track how many foot contacts that's going to be, and then we'll build from there. Once they're closer to like that 400, 500 range, then I feel a little bit more comfortable with them initiating jogging. And with that, it's usually single leg foot contact. So we'll do a lot of jumping before we start running.
Hmm.
Okay, awesome. So how do you feel then about like, I think the most common thing that we've learned is like the isokinetic machines and whatnot, but obviously that's not available in every clinic. So do you do any sort of like strength testing like that before you start building into the plyometrics and the jumping or?
So we do have an isocot, we have a biodex at our clinic. So we'll
Okay.
do that at like 3 months, 6 months, for our ACL patients. It's standard for
Hmm.
everyone.
Mhm.
Usually we want them to be above 80% before they return to run, but that would be like more my post-op patients compared to like bone stress injuries.
Okay, cool.
Yeah, we've talked about that a lot with in our sports elective too.
Mhm.
Like our professor kind of he really encourages us to have our patients at like at least 90% limb symmetry index before we start actually like getting into plyometrics and all of that. So it's interesting to
Okay.
hear it from like a different perspective too, because we've obviously gone to school here for 3 years. So I like having the opportunity to like hear from people who didn't go to OU or who are working in the field now and have seen a lot of patients what they like to do.
Mhm.
Um, I think our next question is we kind of talked about this already with like the Wisconsin index, but do you regularly use any outcome measures other than that one? And I think you mentioned one more. And then if so, like which ones are in your caseload usually?
For runners or for just like different athlete injuries?
For runners probably would be the most like applicable
Yeah.
here.
So I would say for runners, I see a lot of patellofemoral pain. So the CUS PF is very good for like patellofemoral pain specific knee. For our post-ops, we usually use the IKDC. We'll use the ACL RSI just to return to confidence. Other runners, so sometimes we'll do a PSFS, sometimes we'll do the HOOS if it's like a hip pain specific one, but I would say the UWRI is probably like the most
Mm-hmm.
running specific one that we use.
Mm-hmm.
Awesome. And then I know we talked about it a little bit earlier, but is there any sort of like equipment or like favorite drills that you use? I know you talked about focusing a lot on the warm-ups and like making sure that they can do everything in proper form, but like moving past the warm-ups, do you have any like favorite drills or anything that you
Yeah.
like to do?
I would say for my runners, I love, I know I've talked a lot about plyos, but especially for the stress fracture patients, I would say multi-directional, multi-planar plyos are so, so important in this population. What we find a lot with runners is that when they're just doing the steady impact, so such as sagittal with plain loading,
Mhm.
those bony markers really go absent after a while. So there's not really that bone density improvement. So for my runners, they do a lot of like counter movement jumping, a lot of multi-directional, a lot of like jumping and sticking. So that's more from the plyo aspect. From the aspect of like equipment, I love our reformer at clinic. We use it a lot for core stability, and then we'll also do it for like glute stability and glute power development. Um, we have a leg press. I use that a lot. Knee extension machine, hamstring curl, kind of all your like standard. I don't know. Just I would use those with any patients.
Mhm.
But I would say with my runners, I get a lot on the reformer just for that core stability aspect. Um, yeah, just a little bit of everything. I like to use weights whenever I can, especially with the runners. I
Yeah,
find that they don't weight train enough.
definitely not.
Mhm.
On the topic of like equipment that you use with your runners, I know you said you do 2D analysis and you use those biomarkers on your runners. Where do you place those markers when you're doing the analysis?
Yeah, so I usually do so joint line for the knee. I'll do at the ankle, more at their malleoli. I'll do it
Hmm.
at their greater trochanter. Usually I'll do like anterior ASIS, PSIS. Sometimes if I notice that they're getting a little bit more like knee valgum, then I'll do mid joint line anteriorly at the ankle. I'll do tibial
Hmm.
tuberosity. I don't always do anterior at the ankle just because usually you can see it pretty well. And a lot of times their shoes, especially nowadays, the shoes are so big that it sometimes just falls off. And sometimes I'm like, okay, I don't know exactly what their foot's doing in this shoe because the shoe is so cushioned.
Hmm.
Um, in the back of the foot, just to see like kind of their rear foot, usually I'll put two markers on their Achilles. So one a little bit higher, like mid substance, and then one a little bit lower, like calcaneal insertion. Again, with the shoe, sometimes I do that, sometimes I don't. It depends on if I think the juice is worth the squeeze. But I do think it's a good kind of like metric if I can see it to see what their rear foot's doing during their pronation phase. Yeah, that's pretty much it.
Okay, good to know.
I was gonna say, perfect. Building off of that, the shoe wear side of running, do you
Mhm.
have any sort of like specific shoe wear? Like, how do you approach the conversation with patients, sort of determine if, that might be a factor that's influencing their running gait, sort of like, when do you start to dive into that? Because that's such a broad aspect that it could get so blurry so fast.
It's a very broad aspect, and I see a lot of different runners. So they range from the runners that, oh, I've had these shoes for, 5 seasons now. This is like my fifth year running them. And then I have runners that are like, I rotate 3 pairs of sneakers, and I like these pairs, this for stability, this for speed work. So there is a wide range. So a lot of times I'll let the patient kind of lead the conversation with that. So usually in my subjective intake, I'll say, hey, tell me about your sneakers. How long have you had them? Do you wear any orthotics in them? Do you swap them out for like training runs versus like speed workouts? Depending on what they tell me is kind of where I go with my education because
Mhm.
especially with runners, sometimes less is more because they're going to take everything like to heart, nothing with a grain of salt. So when it comes to education on it, if I think that they need a new pair of sneakers, like if they've been running the same pair for like over a year, usually what I recommend is that they go to a specialty running store. So like we have partnerships with Fleet Feet and Second Soul here in Columbus. So it's nice because they've come and talked to us. I have like these little coupon cards that I can give them.
Mhm.
Depending on what they see during the running analysis, it's kind of like a prescription pad. So I can write like recommend motion control shoe, recommend like neutral trainer or whatever I think that they're going to use. And then they can take it there. They can get fitted, they can try it on. I always tell them to like run in it because it feels way different when you're running in it. Usually for those patients, I'll tell them if you run in it a few times and you don't like it, take it back because they will accept it for
Mhm.
a return. But I think the best way to know what kind of shoe is going to fit them best is to have them try it, have them try running in it. Um, Very rarely do I do like the custom orthotics. We do them in our clinic. But I find that's more useful for like some of our more developmentally inclined patients. So the patients that have like history of clubfoot, history of like congenital deformity, or the patients that have like a history of toe walking or something like that. I don't often get into the custom orthotics for our runners just because there's research saying that prefabricated is comparable to custom orthotics.
Mhm.
So usually if they're in the road of, severe pronation, or if I think they could use a little bit of like a higher arch support, I'll suggest it to them, but always tell them to try it outside of clinic first.
Okay.
Good to know. Kind of going off of that, do you ever like refer to a podiatrist for any of your patients with like overpronation or anything like that?
I haven't gotten to the point where I felt like it was necessary. Our ortho team is pretty great. So a lot of them are like foot specialists. So
Mhm.
if I have a patient that I think like would benefit from a podiatrist, usually the reason I'm concerned with that is more from the concern of like the sports aspect of it. I'm not
Mhm.
usually concerned about like their feet themselves.
Mhm.
So if I got to that point, I would usually probably say, hey, I want you to see the sports med provider.
Mhm.
I don't have any podiatrists in the area that I have like that relationship with that I would consider referring them to, especially because a lot of our runners come from internal referrals. So we usually like to keep them in-house as much as we can.
Yeah, no, good to know. Our next question was, and we kind of talked about this already. I know we had talked about plyometrics a bit, and then you gave some strength training exercises. Is there anything else you like to include within your plan of care for a lot of your runners besides like the few ones we've mentioned involving strength training and then the discussion we had on plyometrics?
Yeah, I would say it really depends on the runner, depends on their deficits, depends on what they're coming with. Because we see so much knee pain, I do a lot of like glute med stability, a lot of piriformis, like eccentric control. So it depends on what the runner's doing for that. If I can get a runner in single leg stance, I'm going to get them in single leg stance. That's kind of my motto when it comes to exercises is if you're doing it on a table, they could be super strong with it, but that doesn't mean it's going to translate into their running form.
Mm-hmm.
Um, so yeah, any standing exercises for glute med stability. I love a Captain Morgan. I love a standing clamshell. I love like a Captain Morgan paired with like a retro lunge to a high knee drill. That's really good
Mm-hmm.
for kind of training that like knee drive when they're running.
Mm-hmm.
Um, Other ones that I like, I love glute stability. I love core stability for patients. So like single leg hip thrust with a resistance, a lot of like plyometrics with that. I'll do like Pilates 100 variations with a lot of my runners just for that counter movement aspect of it. Plus, I just like the neutral core position a lot for the core
Mm-hmm.
stability for them. Um, yeah, it's tricky. It depends case by case and like
Yeah,
what they
for
have.
sure.
Yeah. Ideally, I'd have a higher level runner and I could do like all the fun stuff, but a
Mhm.
lot of
Yeah.
times it's like a middle schooler that moves like a giraffe. So
Yeah.
it's very
Yeah.
different depending on how they present.
Kind of on a similar note to that, something I saw a lot in clinic, like I didn't get a chance really to work with a lot of athletes in my outpatient ortho rotation, but we did have like a few, and I had one that was specifically kind of on my caseload, and he had a lot of difficulty with coordination. So I was kind of wondering what you do, like how many of your patients struggle with coordination of running? Because when he was trying to return to run, it was baby giraffe all the way.
Yep. All of them struggle with coordination. No, definitely a lot of them. I would say a lot of that goes back down to like the core control for them. So if the core is weak, the limbs are going to do whatever they want to do. We have to have like good reciprocal core control. Some of the interventions that I really like early on is obviously like a bird dog, a dead bug. Those are going to be like your solid, like foundational ones. I try and move past those as quickly as possible. So sometimes I'll do like paired movements. So if I'm going to be training a step up with a runner, then I'm also going to have them do like a shoulder press just for that core aspect. Sometimes a unilateral chest press with like a dumbbell to get that core control. Other ones that I really like doing, I love the reformer. So I'll do like standing abduction with it. I'll do like seated rows, like in a tall kneel position, because if their core is not firing, like they will fall off. So you have to ease into it, but it's kind of taking the cheating out of it. I really like bear plank series, so I'll have them do like a bear plank and then do a bird dog from that position. They'll do like a bear plank hold and do like reciprocal like upper extremity rows. Really anything if the leg's moving and it's like a unilateral movement, I'll try and pair it with like some upper extremity movement. And I find that that helps a lot with the coordination aspect. If you can get a weight in their hand, then that's even better. But if you can't, then you just kind of have to go with what you've got.
Mhm.
I've seen some really uncoordinated kids. So you really have to scale it down to like if they can just do a step up, if they can balance on one foot, that's great. Like fantastic.
Mhm.
I got you. Thank you.
Yeah. Building off of that, going along with the coordination and whatnot. So I've seen a couple pediatric athletes like throughout my clinical rotations. And do you sort of approach it like you approach the running where it's like, let's pick 1 to 3 things to work on? Because like we can do all these single leg stuff, but there's so many things going on even in like the single leg, or like not knowing how to hip hinge or not knowing how to like get up and tall and retracting your scapulas and whatnot. Do you sort of just pick 1 to 3 things to focus on at a
Yeah.
time?
I would say yes, especially a lot of our patients, so surgical, non-surgical, we're seeing them 2 days a week. And depending on how hard we hit things, they might still be sore that 2 days
Mhm.
later. So if I'm picking 1 to 3 things to work on, the next session that week is usually a different list. But
Okay.
that helps me isolate a little bit more. And then when they get really good at the isolation, that's when we'll train more of like the compound movements. So we'll put it all
Okay.
together. But yeah, I would say if I'm hitting like posterior chain one day, I might hit quads the next day, hit core the next day. I like to break it up a little bit because otherwise, one, it gets boring in PT for them.
Mhm.
Two, it just gets a little bit like they get really sore.
Yeah.
So you kind of have to meet them where they're at. But yeah, I like to focus on like a few things per session. Makes the note
Okay.
so much easier to write too.
Yeah.
Kind of going off of that, I know you said like you'll train a different muscle group every session. How many days a week do you typically see patients? Obviously, it depends on the patient, but like, what's your typical preference?
I definitely prefer 2 times a week, so like every other day. If I can get them hit, like my ultimate preference would be like if I could see them like Monday and Friday and have them hit strength independently on Wednesday. We have this big spreadsheet that we use for like weight training that I'll give to a lot of my runners and like print it off as a PDF. And I'll kind of teach them about like lifting splits. So like, okay, if you're hitting arms one day, you're hitting core the next day, you're hitting legs the next day. A lot of them have never lifted before, they don't have access to equipment. So you kind of have to meet them where they're at as far as exercises. Not always, but a lot of times in my post-op patients, I'll break up their home exercise program into 2 home exercise programs. That way they have like an actual split. So if they're working on like glutes and hamstring one day, we're doing like a very quad focused day the next day. When they're able to
Hmm.
incorporate all of them, then we will incorporate all of them. But my goal usually with their home program, I don't want like filler exercises. I want like
Hmm.
good effort for each exercise. So that's something that I've kind of come to develop because when I first started nationwide, like I would have these home exercise programs and they would be like 4 pages long. Like no kid is doing that every day. Like let's be so for real.
Even the
Um,
adults don't do
Even the
it.
adults, oh my God, especially the adults. The kids are at least motivated to get back.
Yeah.
Yeah, so breaking down the home program, saying like, this is your A day, this is your B day. And then from a clinical sense, I find that that really helps me like narrow down too. I'm like, oh, they always skip their B day. They don't like their B day as much. It's because it's weaker. They don't like it because it's hard. So I know what I need to challenge in clinic, even if I don't need to do a reassessment. I know what they've been lacking in.
Hmm. Good to know.
Totally sort of switching gears and drawing back to your like coaching experience and then what you do now working with both female and male runners. When you're evaluating your athletes or your runners, do you have any sort of screening looking for like reds or like the female triad? I don't know if the female
Mhm.
triad would be as applicable like in the super young, like grades 5, but like in your high
Mhm.
school and you're up to your 24s, like are you looking for the female triad? Are you screening for reds? And then if you do identify like any concerns, what's your approach to like tackling some of those conversations?
That's a really good, that's the $1 million question, right? Because it is a very sensitive topic. I would say It's not always like I have the same questions that I ask every patient. It's very
Mhm.
dependent on their injury. So if they come in with a stress fracture and it's like their third stress fracture, and I know that they're not seeing nutrition at Nationwide, the bells are going off in my head. I'm saying,
Mhm.
okay, this is likely something having to do with either nutrition, overloading, some kind of stress and like sleep schedule. We do have a handout that we developed with the running sig that's like a healthy habits handout. It talks about sleep habits, it talks about nutrition, like fueling before, after practice. Sometimes I'll attach that as just like my after visit summary, like I'll staple it and be like, hey, since you had a stress fracture, here's these things. If it's a patient, so like today, for example, I'm seeing a patient that I've seen like 4 times before, and she's back for another stress fracture. She's already working with nutrition, and I know that she's already like working with her coaches to manage her load. Sometimes it's a conversation of, hey, you're doing everything right. I think it's time for us to get like a bone mineral density scan, like a DEXA scan. That can be a hard conversation, and I usually kind of frame it as like the more information we know, the more we can go off of. In an initial evaluation, if I'm suspecting something like that, I try and make it a little bit more conversational. Like when I'm asking them, like, oh, do you lift? Like, does your team ever have like team dinners? Like, do you guys have like bonding dinners or anything? Like, what do you normally
Mhm.
eat? Like, do you have like a lucky food that you eat before the meet? So I'll try and frame it like more like conversationally, or at least I try
Mhm.
to. I don't know if it comes off as casual as that.
Yeah.
I hope it does, but if I can get them talking about it from like
Mhm.
just like an anecdotal standpoint, then I can see like, okay, are more red bells like going off in my head? Are things like looking pretty steady? And then I'll see how they respond to care. If they're not getting stronger, even though they're putting in all the work, then I'll usually talk to them about like, hey, you're doing everything you can control. There are other things that we need to talk about. Like,
Mhm.
are you sleeping at night? Are you really stressed out with school? Like, what does your diet look like? Are you open to talking to sports nutrition? We're really lucky at Nationwide. We have this awesome sports nutritionist. She's a runner as well. Her name's Akiko. Anecdotally, she runs like marathons and half marathons, but she won the Columbus Marathon like 2 years ago. So she's like the real deal.
Oh
So
Yeah.
when
my
it comes to my
gosh.
runners, yeah, buy-in's like huge with runners. So sometimes if I'm
Mhm.
like, hey, I want you to talk to a sports nutritionist, I'll literally say like she's a runner, she like wins marathons, like she gets it.
Yeah.
And sometimes that helps with the buy-in as well. So it helps to have a team that like has the background in that population. That's not just like doctors that are like, oh, I hate seeing runners because they're just gonna run. Like,
Yeah.
well,
Mhm.
that's not helpful then.
Yeah.
Um, but yeah, anecdotally, I try and bring it up conversationally as often as possible, but I really like having Sakiko as a reference because I can just refer people to her.
Mhm. And then sort of going one step farther into that, working with the pediatric population, how do you sort of approach this conversation with parents?
And that is a great question. So usually if I think that it's going to be like a heavier conversation,
Mhm.
I'll kind of separate the family a little bit. I
Mhm.
like to talk to the parent first, and then I'll bring them in when I'm talking with the kid. That way it doesn't
Mhm.
feel like we're like, I'm 1-on-2 and it's not like 2-on-1. But
Mhm.
usually on those days, I've had like one kid, he wasn't a runner, he was a boxer,
Mhm.
and he had a history of wrestling. So obviously, like, there's a little bit of like nutritional concerns already lighting up in my head. But he
Mhm.
was in for repeat stress fracture of his back. So I'm sure you guys ever learned about like spondylolysis, spondylolisthesis. It was
Mhm.
the second spondy. So already alarm bells are going off in my head. I had seen him before the last session. He like got dizzy because he didn't eat beforehand.
Mhm.
So that day, for example, I had him go and warm up and I was like, hey, mom, I'm going to talk to you about the schedule. While he was warming up, I was like, hey, I am concerned about like eating habits relating to like a sports participation, but then also this repeat injury that happens to be a stress fracture in his back. She said
Mhm.
she was concerned too. I was like, later this evening, like when we're scheduling, when I bring you back to like talk about how the session went, is it okay if I like broach this topic? Like, how do you think he'll respond? Parents like to be looped into the conversation.
Mhm.
It very much ranges and like how much control the parent wants to have in that conversation. Like sometimes they're like, done, he's going to see a nutritionist. We don't even need to talk to him about it.
Mhm.
Mhm.
Usually I like to talk to the kid about it anyways.
Mhm.
Sometimes the parent's like, well, it depends on what they want to do. And I'm like, okay, well, do I have your support at least? Like, is this something that I could have you as a trusted adult that could also talk to your kid about this at home and maybe like provide like nutritional snacks or like provide options that might make it a little bit easier to hit those goals that we're looking for.
Hmm.
Um, Parents are always tricky. Sometimes parents are really bought in, sometimes parents very much disagree. Sometimes the eating habits are a product of like the home environment themselves, if there's like disordered eating habits with the family. So it can be like very case by case. So that's just one example where the mom was really supportive and I got her buy-in before I talked to the kid.
Mhm.
But you'll kind of know, especially if you work with this population, there are parents that it's easier to treat them than the kid, and there's parents where it's harder to treat them than the kid.
Hmm.
Yeah.
But you do kind of have to treat both of them in your care, which is crazy.
Awesome.
Given the fact that you were talking about how like buy-in is really hard with runners sometimes,
Mhm.
and obviously I think like something I've experienced in clinical or like in my clinical rotations has been buy-in with parents is also very difficult sometimes. Is this a conversation you're waiting till after the initial eval to have? Like, would you ever have this conversation on day one, or would you kind of wait until you've built rapport with that patient and their parent?
It's a good question. I would say for me, it does depend on how the initial evaluation goes. You know, if we're joshing, if we're having a fun time, it might not be a formal conversation, but I might print off that healthy habits handout and just like
Hmm.
staple it and be like, hey, we didn't really get to talk about this. I want you to look over it. Let me know if you have any questions next time. We might talk about it in the future.
Hmm.
Um, I love to stunt on my patients day one. So like my runners, I'm like, oh, we have the same watch. Like, oh my gosh, you ran in Cincinnati. Like, I remember when I won this cross country. Like, I love to stunt on my patients. Like, if I
Mhm.
can get them like looking at me like, wow, she's the real deal. I know it's like whatever, but for the runners
Mhm.
especially, if I tell them like, oh, I've done like 5 marathons, they know I get it. And it is a very like inclusive community. So I always like to say
Hmm.
like, oh, I'd love to go for my runs. Like, isn't this weather great outside for running? If you can relate to their sport and kind of like, I don't know, like butter them up a little bit, like, oh my gosh, I love this athlete. It helps a lot with the buy-in. Like, even if they
Hmm.
don't know
Mhm.
you, they know the sport, they know the background, they know you know it. That makes a huge
Mhm.
difference.
Hmm.
Um, but usually, no, I'm not having that conversation day one. It's usually like the
Hmm.
handout at most, and then we'll talk about it once I know them a little bit
Hmm.
more.
Gotcha. No, that's helpful. Our other question, kind of switching topics a little bit. I know we talked about like I had asked that question about podiatrists, and you had said you kind of usually refer to like a sports med physician, but do you frequently involve other healthcare providers in your plan of care, and how do you collaborate with them, and what does it look like in your day? So like athletic trainers, nutritionists you talked about, dietitians, coaches, that kind of thing.
Yeah, it depends on what the patient's kind of looking for and how they're presenting. If a patient's doing really well and they're like returning to sport how I would expect them to, usually my communication with like the coach, the athletic trainer comes in the form of like I'll print off letters for them. And it might be like the running progression I'm giving them. It might be like their restrictions for their sport, like their practice, kind of generic. But that's usually my communication with them. Rarely I will kind of like call athletic trainers, call coaches. But our biggest thing at Nationwide is if they're not like an NCH partnered athletic trainer, which some schools around the area are, some schools are not.
Hmm.
We do have to have them sign like a liability form as far as like communicating with someone outside of care. So
Hmm.
if I know that a patient wants me to like call their athletic trainer and like talk to them through it, which I do for a lot of post-op patients, usually I'll send that home with them is to have the athletic trainer like fill it out, have their parents sign it, and then once they're signing it, then I'm calling them.
Hmm.
Um, I would say phone conversations don't take up the majority of my communication. Usually it's emails if they sign off on that form. And usually the letters that I send home are pretty sufficient. As
Hmm.
far as sports med docs, that changes depending on like what kind of injury it is. If
Hmm.
it's more like a non-operative, non-surgical patient that is progressing well, usually I'll send their doctor kind of an update whenever they have a follow-up visit. I'm like, hey, things are going great. Let me know if you have any questions. If they're not going well, it depends on the doctor and it depends on my relationship with them. We have a bunch of doctors at our Westerville campus that like our upstairs is the sports med floor, and our downstairs is all like the physician offices. So if it's a doctor that I know things are not going well, or I know the patient's going to be like not happy with how they're progressing, sometimes I'll go downstairs and I'll like catch them in between patients and be like, hey, can I give you an update on this patient? Which I think
Hmm.
that they tend to appreciate because they're not going into the office like blind on how they're gonna like things are gonna go down.
Hmm.
Um, So that's if they're in office. If they're out of office, usually I'll shoot them either like an Epic secure chat, I'll shoot them like an email, just let them know how things are going. With
Mhm.
our post-op patients, it's a little bit more structured. So obviously they have their follow-ups at like 6 weeks, 3 months. Sometimes if things aren't going well, they'll do 4 months and then 6 months, 9 months, and a year. So anytime that we have that, usually we have like a handoff phrase that we send to them. The most important things that we include is like how they're doing on their strength testing. So we'll include their biodex metrics, sometimes isometric, sometimes isokinetic, depending on how far they are out. Usually I'll send over like any movement screening tool. So like if they did their single leg hop test, if they did the LESS, the 505, I'll send those results over to them as well, just because I feel like the doctors appreciate to see that. Um, Usually that's only at those structured follow-ups unless something happens. So
Mhm.
I have had some patients that like, every blue moon, knock on wood, this doesn't happen, but I've had like an ACL patient, we're doing like cutting drills in clinic and they sprain their ankle. So
Mhm.
obviously with that, I have to shoot the doctor a message like, hey, this happened. I think they're fine, but do you want to see them?
Mhm.
I think the doctors appreciate getting let know, and it kind of like reduces the amount that the patient has to communicate with them. If I'm the one that's like, hey, do you want to see them for follow-up? That makes the parent feel a lot
Mhm.
more secure as well.
Mhm.
That's usually my communication. Usually emails, usually smart messages, occasionally phone calls, and occasionally I'll go down and like talk to them in person.
Mhm.
Okay. Yeah.
Okay, good to know.
Yeah. Going back to the parents, I am treating both the patient and the parent and getting just the parent involved. Is that something you typically try and do, especially if it's like your first time seeing a patient? Do you try and implement parents and like your plan of care and your goals and like what exercises they need to do at home, or does it just sort of like case by case?
Yeah, so usually first visit is the only visit that the parent will like come back for the visit. And I'll
Hmm.
tell them then day one, like at the end of the eval, I'll be like, hey, for the next day they come in, our waiting area is like separate. Like the parents will be downstairs when they come up for sports med.
Hmm.
So that's really nice. I love that for like independence of the patient. But I do have some parents that are like kind of clingers that they're like, oh, can I come back? And I'm usually like, no, like,
Hmm.
no, you cannot come back. Like not to be mean, but no, this is your
Yeah.
patient.
Yeah,
Like
that's part of
it's re
Pete's.
it's part of Pete's, and sometimes the parents are open to that. Sometimes they're like, oh, can I just like stand in the background? I'm like, if you really want to, they end up playing on their phone. So I'm like, what was the point of this?
Yeah.
Um, but usually day one, as far as home exercise program, I'll ask the patient like, hey, how many exercises per day do you think is a fair ask for me to ask you to do? So more the patient than the parent.
Mhm.
Sometimes the parent chimes in on that. So if the patient's like 2 exercises, I'm like, okay, each exercise takes like maybe like 2 to 3 minutes to do. So you're saying you can devote 5 minutes of exercise per day to get back to your sport that has 2 hour practices. And usually, if I lay it out like that, the parent will be like, no, you're doing way more than that. And I'll tell the patient, like, yeah, this is your sport right now. Like, what used to be hard, that's not hard anymore. This is hard now. So we got to put like 2 hours of work to this hard to get back to this hard. Usually, I get a lot of parent support on that. Rarely the parent will be like, I did PT and it didn't work for me. So this isn't going to, very rarely. But usually they're pretty bought in with that.
Oh, that was such a good way to put that. Thank you.
Yeah.
Yeah.
No, that made a lot of sense. Um, do you have any advice for how to provide education to like pediatric athletes and runners, such as like I feel like a lot of runners are known for like pushing their limits a little too far. So how do you have that conversation, provide patient education?
That's a good question. So I will say, I guess to ask you a question, like follow up,
Hmm.
like when you say like education, like not pushing it too far, do you mean like with their exercises, with like getting back into training load? Like, what do you mean by
Hmm.
that?
Mostly like getting back, like returning to run, I think is like a lot of athletes and I think a lot of younger athletes because they're trying to get into like college scouting and all of that, they tend to go back a little too soon and push themselves a little too hard, and it leads to higher re-injury rates. So how do you have that conversation with them?
Yeah, that's a great question. For the runner specifically, so there are a few tools that I like to pull out of my back pocket when the runner's like getting back into sport, especially for the stress fracture kiddos that are like running all year round, doing workouts all year round when it's really not necessary. One of those is the American Pediatric Association, like the AMA Pediatric SIG. they have this handout that talks about early sport specialization. I love printing that off. It's like a PDF you can find online, but it talks a lot about how many hours a week a patient should be practicing like a single individualized sport, how many competitions, how much rest they should take off per year. That is a huge conversation with runners. Gymnastics tends to be a really big conversation with them because that's a year-round one.
Mhm.
Even like soccer players now, like you get the club season, you get the sports season, like they're doing like lifting with the team afterwards.
Mhm.
If I'm talking to it with a parent, then I'll usually say like number one indicator for burnout in pediatric athletics is the child isn't driving the bus. So what I mean by that is like the parent played this sport, they're like signing them up for all of this. The patient doesn't like overtly say that they're interested in it. So usually I'll be quite blunt with them. I'm like, if the kid wants to do it, that's awesome. But if they're not initiating
Mhm.
that conversation, that doesn't mean that the conversation has to be initiated.
Mhm.
Um, from the kid's standpoint, usually I'll break it down into simple terms. So I'll say, like, you're 12 years old. Based on this research, the amount of hours you should put into your sport per week shouldn't be over 12. And I'll break it
Mhm.
down like what that means is like if you have 5 days a week that you have a practice, you shouldn't be practicing 3 hours every single day. It should be like 2 hours maybe, and you should always have like a day of rest, like at some point during the week. We'll talk a lot about what rest means. So, unstructured play is usually what we recommend. So, if they're resting, but they're like doing a stationary bike workout or like cross training, that's not resting.
Mhm.
Resting should be like they're still active, but they're like playing with their friends. They're like going bowling, they're going to top golf. So, we'll talk a lot about like what rest looks like because a lot of runners will say, like, I rest all the time. No, they don't.
Mhm.
They just bike,
Yeah.
they do the elliptical, they do something else.
Mhm.
Um, so I rely heavily on that handout. I feel like having the American Medical Association like name on it helps a lot with buy-in. Sometimes for our runners, like when it comes back to like the return to sport progression, at the end of all our return to sport progressions is like a maintenance phase. Talks a
Mhm.
lot about like acute to chronic workloads. So like general mileage increases over the course of the year. If you take like a month off, you can't like pick up where you left off. You have to start down a little bit. It'll talk about like the rest days per year, how many months off you can take off of running, like structured running workouts per year for it to be like successful when you try and peak. I'll
Mhm.
talk to them a lot, especially if they have indoor track involvement. So usually I'll tell them like your body's designed for running, that you can peak in performance twice per year. If you're doing 3 competitive seasons, like you have to recognize that if you're trying to peak 3 times per year, something's going to give. Like the body's not designed to do that from a running
Mhm.
athletic standpoint. So
Mhm.
I'll talk to them a lot about that, especially getting into indoor track season, especially
Mhm.
because it's not OSHA sanctioned. So there's not really any constraints on how much they should run. So I see a
Yeah.
lot of overuse injuries with that.
Mhm.
Switching gears a little bit for your post-op patients when it comes to them, I rely a lot on the literature. So there's conflicting reports out there about like return to sport readiness, confidence. There was an article, I think Mark Paterno out of Cincinnati Children's published it with Laura Schmidt in 2020 that talked about like the more confident kids have a higher risk of tearing their ACL when they get back. So usually what I'll talk to my patients, it's a conversation throughout their care, but I'll talk about, even if you're feeling confident, even if you pass your tests, that doesn't mean that this graft is fully healed, that that surgical tissue is like where it needs to be. It's, we have to kind of frame it as that because I do have some kids that they pass their strength tests, they're 100% on the isokinetic testing. They get over 100% on all their hop tests. They feel confident, they feel good, they go out and they go out too soon. So I'll talk to them a lot about like time to return to sport. We like to say at least 9 months, but as close to a year as we can get, that's really what we want. I always ask them, like, even if you feel good, like, is the risk versus the reward, like, is it worth it at this point? I like to use like patient-centered care model. So I'll ask them, like, is there a reason why you need to return now versus 3 months from now? If it's something like a scholarship that they're going for, then I'll kind of support them in that as long as they know the risks. But if there's not anything that's time dependent, I'll say, hey, even though you passed everything, even though you look good, even though you feel good, if we wait, you have like X amount chance less of tearing your ACL. And I think that might have been like a Paterno article as well. They talked about like 9 months, 10 months, 11 months, 1 year, and like reduction in risk, just waiting a little bit longer if they keep at their intensity of training. Um, so it depends. I like to frame that like day one. Like when they come in, I'll be like, okay, when are we getting back? Like, when do you think you're getting back? And if they're like, oh yeah, I want to get back by next season, no, like let's look a year from now. Like let's see what's going on then. Yeah, that's kind of my thoughts on that.
Okay, great. Thank you.
Yeah, I
And
think that
then,
was really helpful.
yeah.
And I think we only have 2 questions left. So I think sort of, I know you did a sports residency, which fantastic, hopefully. But is there any sort of like continuing ed classes or like since there's not really like a specialty like there is like a sports specialty but there's
Mhm.
not like a running, is there anything you recommend kind of doing in the future to gaining more experience and just becoming a more thorough clinician in regards to running?
Yeah, I think that's a great question. I think mentorship is so important. So if you know what kind of running you want to get interested in, so whether it's pediatric, whether it's the research side with like gait analysis, whether it's collegiate, there are so many good mentors that are out there. So for me, because I knew I wanted to do pediatric, it made sense to do a clinical with like Jeff Taylor Haas. We collaborated on the poster that I presented even after like my clinical rotation was over. I was doing my residency. So I think the biggest thing is like putting yourself out there, finding mentorship in the field. There are some continuing ed courses that I would recommend. So there's one conference that's like the Running Pediatric Conference that Cincinnati Children's hosted. I thought that was really helpful. It was from the standpoint of like clinician and coach. So we got to hear like the coach's side of things as well, which was kind of like a perspective change. I always love like CSM. I love that they kind of divide up their posters and like you can meet the mentors that like, oh, 1040, I've read your article a million times, like here you are. So that's kind of cool. But yeah, I would say like conferences are a great place to start to kind of like dive into your niche, whether it's research, whether it's clinical practice, and then going from there, like finding your mentor that's going to be the best fit for you.
Awesome, thank you so much.
All right, our last question. As third years, we're getting ready to graduate and become independent clinicians. Do you have any advice for our class regarding like the field of running or in general going into PT?
Oh, that's a good question. I feel like I was just in your, like, I was just where you were sitting. So, in terms of running, I would say just in general, like PTs tend to be go-getters. There's high burnout in our profession. Keep in mind, like, you have our whole career ahead of you. So, if you have goals, you can definitely like break them up into like sizable chunks. My sister likes to say this is a funny expression, but she's like the best way to eat an elephant is in small bites. That's so true. Weird expression, but very true. But I would say like if you have big goals for your career, if you know that you want to like center yourself in like a very niche field, don't sprint there. Like take it in sizable chunks, like work towards those goals throughout your career, but don't feel like you have to sprint there because you might get there and be like, well, I hate this. But if you take it and you break it up, then it makes it a little bit easier and it refines what you're actually interested in. Because you might start thinking that you're interested in one thing, but if you take it slow, then you might find like the right path for you. Um, I would say that's like my number one like word of advice for your age.
Okay, thank you so
Yeah,
much. That's super helpful
yeah, I
as
think
people like
that's
as people who tend to be type A, like you said, I think like PTs, we tend to
Mhm.
really like try to not live in the moment and keep focusing on what's ahead. So
yeah,
I think
Mhm.
hearing that like from a person who's already been practicing is like a nice reminder of our whole lives are ahead of us still,
yeah,
Mhm.
and
Yeah,
we're
you'll
just
have a long
beginning.
career. You're just beginning. Like, there's
Yeah.
so many things of PT and like it is so specialized, but like you come out a generalist, like explore your options, try everything, like figure out what you
Mhm.
actually like.
yeah.
Yeah.
Okay.
Okay, well, thank you so much. Do you have any questions for us before we end the recording?
I don't think so.
Okay.
But feel free, you guys know my email. Feel free to
Hmm.
reach out if you guys need anything. If you want to come and shadow, if you want to come and
Hmm.
hang out, just let me know. Okay.
Okay.
Awesome. Thank you so much. We really
Yeah,
appreciate you
Yeah, thank
taking
you so
time out of your
much.
day.
This has
of
been super
course.
informative, so I'm glad we had the opportunity to do this with you.
Yeah, it was good. Thanks for inviting me. I appreciate it.
Yeah, of
Yes, of
course.
course.
All right,
Thank
go
you
ahead
so
and
much.
end the recording.